Hi, my name is Penny Hallett, and I'm an assistant professor at McLean Hospital and Harvard Medical School, and I'd like to thank the organizers for the opportunity to speak today about new scientific and clinical developments for autologous stem cell therapy for Parkinson's disease patients. And we feel that we have a major solution for a serious clinical problem by using a regenerative medicine approach, and that we'll actually be able to alter the trajectory of patients with Parkinson's disease. So Parkinson's disease is a disease of aging. And in the USA, the number of patients with Parkinson's disease is expected to double over the next 30 years. And with the lack of treatment options and with its increasing patient population, this presents a major healthcare problem. And Parkinson's disease is a movement disorder, and it's related to dopaminergic neurons in the substantia nigra. And this has been well established for the last 50 to 60 years. And the movement disorder in Parkinson's disease occurs when around 70% of the dopaminergic cells or synapses are lost. And at that point, the patients are no longer able to initiate movement and present to the clinic with the typical motor symptoms of the disease. The mainstay treatment for Parkinson's disease is pharmacological replacement of dopamine using levodopa or dopaminergic agonists, which drive the dopamine receptors in the striatum. And although efficacious for several years, these pharmacological treatments do eventually create a different movement disorder called levodopa-induced dyskinesias, which can become very disabling for the patients, as well as wearing off of the efficacy of the treatments. And in order to counteract these dyskinesias, we can carry out deep brain stimulation in a subset of patients, but this really just reduces the side effects of those pharmacological treatments. And another approach is to generate the precursor for dopamine using gene therapy by flooding, and this floods the striatal dopamine with enzymes that convert dopamine. But a more direct approach is to actually implant new dopaminergic neurons back into the brain. And so by implanting the dopaminergic neurons and replacing the dopaminergic synapses, we can actually normalize biofeedback of the dopaminergic transmission. And this is the only way of actually providing physiological dopaminergic transmission in the brain in Parkinson's disease. And we know from our experiences of the fetal cell transplantation field in Parkinson's disease that these transplanted dopaminergic neurons can actually be efficacious for 10 to 20 years or more in the patients. And so our approach is to obtain the patient's own cells using induced pluripotent stem cells, or iPSCs, to derive the midbrain dopaminergic neurons. And this provides a new technology and a new treatment modality that can solve a serious problem and really provides a one-and-all treatment for patients with Parkinson's disease. So our team has been involved in several major discoveries leading to where we are now with the autologous cell therapy approach. And so this includes the use of embryonic stem cells to derive functional dopaminergic neurons, and then more recently, the use of iPS or induced pluripotent stem cells to, again, derive the functional midbrain dopaminergic neurons. And we most recently showed that these iPSC-derived dopaminergic neurons, using an autologous transplantation approach, could provide functional efficacy long-term in a non-human primate model of Parkinson's disease. So what if we could replace the patient's neurons with their own new cells? So our innovative approach is to take blood from patients with Parkinson's disease and to reprogram the T cells into isogenic iPSCs, and then to differentiate these iPSCs using our patented approaches into dopaminergic neurons of the midbrain subtype, and then to cryopreserve these dopaminergic neurons, which we then perform extensive quality control testing on. So back in 2015, our team showed that the autologous transplantation approach could result in functional improvement long-term in Parkinsonian non-human primates. And so after 2 years after autologous transplantation into this Parkinsonian NHP model, we showed a sustained increase in spontaneous locomotor activity, as well as improvement on an objective and automated movement analysis panel of measuring the animal's motor function. And then at 2 years after the autologous transplantation at postmortem, we saw good survival of the dopaminergic neurons in the transplanted putamen and excellent reinnervation of the denervated putamen. And since this work, we followed up in additional studies in additional animals and shown again an improvement in motor activity long-term, as well as excellent survival of the dopaminergic neurons after transplantation. Earlier this year, this work was actually replicated by an independent study that again showed the efficacy of the autologous transplantation approach in a Parkinson's disease non-human primate model. And interestingly, in that study, they actually compared the autologous and the allogeneic approaches and showed that the autologous approach was more efficacious than the allogeneic approach. So what are some of the advantages of the autologous iPSC approach versus allogeneic approaches? Well, the autologous approach requires no immune suppression in patients, whereas competing allogeneic and MHC-matched cell therapy approaches will require some long-term immune suppression for 6 to 12 months or more. And we know that there are significant immunological effects of the allogeneic transplantation approach, and that also that the autologous cell therapy approach, that these transplants are potentially better integrated in the brain with better axonal outgrowth and networks, and also have better functional effects than the non-autologous transplants. And using experiences from other disease indications, comparing the autologous versus allogeneic cell therapy approaches, for example, in bone marrow transplantation, we can use some of these experiences and perhaps apply them to brain degenerative diseases like Parkinson's disease. For example, the increased cost and morbidity for failed allogeneic transplants. So shown here in this slide is a typical Parkinson's disease patient's journey from the first year after diagnosis for 20 years or more. And so when patients are first diagnosed, they're administered dopamine replacement therapy using levodopa or dopaminergic agonists. But as I mentioned, this really has a diminishing return because of the side effects and the wearing off that are associated with long-term use of these treatments. In a select subset of these patients, deep brain stimulation can be used to reduce the side effects of the pharmacological therapy. But cell therapy approaches, including our autologous cell therapy approach, can really provide a one-and-all treatment for patients with Parkinson's disease. And we believe that this cell therapy approach can be initiated early in the patients, early after the disease diagnosis. And then, again, based on our work or based on what is known about fetal cell transplantation in Parkinson's disease, we expect that the cell therapy, the dopamine neuron replacement, will last for 10 to 20 years or more in those patients. So here's a snapshot of around half the treated patients with Parkinson's disease in the USA. And shown on the left is shortly after diagnosis, and then on the right is 5 to 15 years after diagnosis with Parkinson's disease. And so again, the majority of the patients will develop levodopa-induced motor complications. And of those patients, around 10,000 patients per year are eligible for deep brain stimulation. And for the autologous cell therapy approach, we believe that once a pivotal trial shows good effects, that there will be a market of around 10,000 patients per year. And for testing the autologous approach, we will initially start with later patients. But if successful, we believe that the healthcare market will favor an early treatment of patients. And with expanded surgical capacities, this number could go up if this shows to be a superior and useful treatment option. So last year, our team began in 2020 an NIH Create Award we're the only team in the US doing this with the NIH. And so this is going to enable us to progress the autologous dopamine neuron replacement to the clinic. And so right now we're performing safety and efficacy IND-enabling studies and manufacturing the dopaminergic neurons for patients at the cGMP facility. After the IND filing, we'll then perform an interventional open-label clinical trial in patients with sporadic Parkinson's disease, and then followed by a pivotal registration trial. And of course, there are many groups and collaborators involved in this work, including our team at the Neuroregeneration Institute, our collaborators at the Cell Manipulation Core Facility at DFCI, and the neurologists and neurosurgeons at Brigham and Women's Hospital. And with that, I'd like to thank you for your attention.